Hello, and welcome to Covered, COVID Vaccine Equity Research Dialogues. I'm Allison Buttenheim at the Leonard Davis Institute of Health Economics from the University of Pennsylvania, here with Harold Schmidt, Assistant Professor from the Department of Medical Ethics and Health Policy at the Perelman School of Medicine. And our guest today is Angela Shen. Dr. Shen is a visiting research scientist at the Vaccine Education Center at the Children's Hospital of Philadelphia, and also a retired captain in the US Public Health Services. We are talking today about a new date that's been put on the calendar by the Biden administration, May 1st. As of May 1st, President Biden has said that all states need to abandon or move on from priority schemes for vaccine rollout and make all adults eligible. Harold, what does this mean?
Well, in many ways, I think this is really good news because everybody's impatient. Everybody wants to get that vaccine. But I think especially for our purposes here, what's important is that the equity story isn't over with that. So thinking there'll be vaccines for all doesn't mean that everybody will get a vaccine, right? To illustrate this, we have here what's known as the spaghetti chart, thanks especially to Kate Miller, our collaborator from Ariadne Labs here. So if you look at this chart, what this shows you is two different sequences of priority groups, one by the Advisory Committee on Immunization Practices and the other by the National Academies of Science, Engineering, and Medicine. And the main point of this chart is simply to say you can organize these priority groups differently. And that's what most of the discussion so far has been focused on. And in a way, you might say, well, we're done with that. So all the equity discussion is over. And it's not, because what matters really is that within each of these groups, we still want to think about how we make sure that more vulnerable people get vaccines first. And that doesn't end when we get to the general population. It's just as important then. Because think about it, there'll be people who at that point have not had a vaccine for 4 months. And many of those people will be literally at the end of their ability to absorb the economic shock. So it's really important that at that point too, we make sure more vulnerable populations get vaccines first. And that people who can wait safely longer do wait a little longer. So here's another chart from our study, in fact. So we looked at how are different states using disadvantage indices. And what's really interesting is that at the end of last year, we saw that there were 19 states that used the disadvantage index in a range of different ways for allocating vaccines. And at the end of January, this has really increased to 29 states. So more than half of states are currently using these indices. That's really where both public health and equity stand to gain simultaneously, because by vaccinating more disadvantaged populations, we are also vaccinating people who are more likely to get the virus, who are more likely to spread it, who are more likely to die from it. So it really is a win-win for both equity and public health to do that.
So, since the May 1st announcement came down, there have actually been some states that have said, we're not waiting till May 1st. We're going to move to all adults being eligible sooner than that. Alaska, the first one to go, actually already eligible, all adults eligible. Angela, how's that going to work? Where was Alaska before that announcement? How is this likely to impact equity in that state?
Alaska is a very large state. It's very rural. Its public health infrastructure and all public health departments across the country in each jurisdiction are wired just a little bit differently on how they function. And so in Alaska, how they vaccinate in remote villages requires an intense amount of transportation, planes, snowmobiles. And so when you get there, you're going to vaccinate a number of different villages while you're there. And that's going to look a lot different than other states with higher urban centers or different types of providers.
One thing that's also special about Alaska is that on the whole, we're allocating vaccines to jurisdictions proportional to population. But in Alaska, there were some other channels too, right, that also in a way function as an equity weight in terms of getting to equitable allocation more quickly. Can you unfold that a little more on it for us?
In Alaska and in a number of states, the Indian Health Service provides health services to tribal and American Indian nations. And so given that Alaska has a number of IHS clinics and sites, as well as a reasonably large proportion or population of Alaska Native American Indian, then the allocations to federal entities, so federal entities like Indian Health Service, federal entities like Bureau of Prisons, federal entities in the government infrastructure, they also get a direct or a different allocation of vaccine. It flows through that pot of vaccine doses differently than the general population. But of course, the same 3 authorized vaccines.
Harold, one thing, that's been talked about in every jurisdiction that I've spoken with is this idea of, leftover vaccines at the end of a clinic day, or surplus vaccines that, might go to waste. How do we think about, priority schemes and equity for those leftover vaccines?
I think that's also so important. That by the point we get to vaccines for all, we have made most efficient use of the vaccines that we have, right? And B, it illustrates the same issues that arise when we are allocating vaccines to all. And so the first point is, of course, that we don't let any vaccines go to waste. We want to make them go as far as possible. And there have been quite a few initiatives that have been set up where people try to connect people with leftover vaccines so that they're used up quickly. But a lot of them are internet-based, so they face the same kind of barriers that we've seen so far with signups for vaccinations, right? Such that people who are more internet savvy, who are better connected, are more able to get those vaccine allocations. And I think a key lesson there is that as much as these initiatives should get credit for doing something important, they too, and especially these initiatives, should apply something like a disadvantage index to make sure that among the pool of people who register for these initiatives, more disadvantaged people are getting larger shares of leftover vaccines than better off groups.
We've seen an interesting implication of that just this week in Philadelphia, which has a FEMA clinic, a large, 6,000 dose a day FEMA clinic, which was all appointment based for the first week or so. Just today, they've shifted to half of those doses, 3,000 a day, going to walk up, but they have to be from high disadvantaged zip codes, high COVID burden zip codes in the city. So it'll be really interesting to see how that rolls out, and also a different plan for dealing with extra doses at the end of the day.
So we know we're doing a lot of vaccinations, but what we probably aren't all that clear about is, well, who's getting vaccinated? It's great to have lots of people being vaccinated, but it's more meaningful if we have more people who are more likely to get and spread the virus be vaccinated. So Allison, what's your sense from looking at that one interesting study about how confident we can be that for each of the states we'll have a good understanding of how they're doing in equitable allocation? And again, the Biden COVID plan also asked states to use a disadvantage index to report on how they accomplish equitable allocation. What's your sense of how optimistic we can be about that?
Yeah, that's a great question, Harold. And I'm a big dashboard junkie. Maybe you guys both are too, keeping lots of vaccine dashboards open on my browser at all times. I really liked this Health Affairs blog piece that came out from Tori Hogan et al. They looked at all the state dashboards and said, what can you learn from the dashboard? And if equity is your interest, do these dashboards give you enough data to see how a state is doing with equitable rollout? And they found only 28% of the dashboards even broke down doses delivered so far by race ethnicity. They also looked at how easy is it for providers to become vaccination providers through the state websites, and also how easy is it for people to find where vaccine is available and make appointments. But in terms of the sociodemographics and the geographic data, there were some gaps in jurisdictions really giving you a good snapshot and a good sense of change over time for how well they're doing. And this is going to be huge after May 1st. If supply really is where they hope it will be, then the question becomes who's taking it up, how good is coverage, and what are the equity implications?
But Angela, what's your sense to what extent states might actually be doing better than we know from the dashboards, right? It might just be that we're going at such a crazy clip that they're not able to show everything they're doing. Do you have more confidence in the large amount of missing data that I think we've encountered in a number of different places, that we will have a good sense on May 1 about equitable allocation?
I was going to say that's $1 million question, but I actually don't know what value or price tag to put on it. It could be the $5 million question, or adjusted for inflation, it could be the $12 million equation. So I think that folks are very interested. There's a number of positives, believe it or not, that have come out of COVID. And one of them is really highlighting what we're talking about. Kudos for starting this to you both. But then the second is also this appreciation of how to capture that data. But a third piece is a lot of people probably don't recognize or realize that we don't have one national immunization registry. And so we have 62 different independent, somewhat of a network of registries for which we don't necessarily have really high data saturation across the lifespan. We capture probably around 96, 97% of kids because we have their birth certificates and those records we can slide in there. Probably around 87%, 88% for adolescents. But for adults, we're barely kind of peaking at 60% in terms of how much data is in there. But I think that where you're trying to get at is around that data and the data capture. and what that looks like by race. And I think the key thing that I see is that it's probably a little bit better than we think because we're flying by the seat of our pants. And two is the data is still coming in. So we're just really beginning our vaccination programs. And three, I think, is that will be really important when we hit this kind of plateau. So you have a lot of vaccine and you have a lot more vaccine than you have people who want it. And so at that point where we hit this kind of inflection point or plateau, there's going to be a need to look at that coverage and to take a look to see where pockets of unimmunized or unvaccinated folks are. And I think that's where, when we take a look at what sorts of the disparities there are, what we're talking about here is not done. We're not going to be done when we have a lot of vaccines in the refrigerator. We're going to be done. It's going to take a while because we're going to take a look at why folks aren't getting it, how to get them get it, and where they are.
So Angela, we know from the doses that have already been administered that we're often missing race, for example, on that data, which makes it hard to show whether there are racial gaps in coverage. With the eligibility sort of going away, or all adults eligible after May 1st, can we just stop collecting racial data on our doses administered?
I think that it'll still be collected. And I think it's important to collect as we monitor vaccination coverage. And in order to kind of take a look when we have enough supply and when we focus on the fair as opposed to the fast, to see which communities are unvaccinated or under-vaccinated. So I think it'll continue to be very important.
That's great. And I think we can wrap up there with the really clear conclusion that May 1st is not the end of anything. Right. It really is going to be the start of much more surveillance and analysis needed to make sure that this was both a fast and a fair rollout of this largest vaccination campaign in human history. Thanks for joining us today. I'm Allison Buttenheim, a senior fellow at the Leonard Davis Institute, along with Harold Schmidt, also a senior fellow at LDI, and our guest, Angela Shen, also a senior fellow at LDI, as well as a visiting research scientist at the Vaccine Education Center down the street at CHOP. We are Covered, COVID Vaccine Equity Research Dialogues. We're delighted that you are here today and hope you can join us again. Thank you.